Thank you very much, Wendy. I'm just going to share my screen so that you folks can see what I'm going to talk about. There it is. So I want to thank Wendy and Caitlin for inviting me to speak with you all today. Hopefully you can hear me all right. You're welcome to send me a message in the chat if I'm not speaking clearly. Or I also have a tendency to get nervous, so I might actually speed up my voice. So please let me know if there's something that I can change to make sure that you can take in all the information that I have to provide for you today. So this is just a brief outline. Wonderful, thank you, Mary Ellen, of what we're going to be talking about today. So really we'll be doing a lot of background information, so a lot of definitions and epidemiology of drinking in Canada. We'll talk about the risk factors for alcohol misuse among older adults, some common symptoms and health consequences of significant drinking. We'll talk broadly about screening definitions and what best practice guidelines suggest for screening for alcohol-related problems among older adults. And then we come to the meat of the presentation, which is the introduction of the Senior Alcohol Misuse Indicator tool. And I will use two case examples, one based in the community and one in long-term care, to help illustrate how the SAMI can be used, how to score it, and what it means. And if I don't have you hooked by then, I'm hoping to hook you with a picture of a pair of my children who are very attractive, or you can just agree with me that they are cute even if you don't believe it. But I hope this will be informative and hopefully a little entertaining at the same time. So I've heard that you folks really like real-time polls. So this is the one of two polls that I have embedded in the presentation. And so the first question is, do you know what Canada's low-risk drinking guidelines are? And I think Caitlin's going to put that up for everybody to put their answers through. So the options are no more than 3 drinks per day with weekly maximum of 15 drinks, regardless of sex. 2 is no more than 2 drinks per day with a weekly maximum of 10 drinks, regardless of sex. 3 is no more than 3 drinks per day with a weekly maximum of 15 drinks for men, and no more than 2 drinks per day with a weekly maximum of 10 drinks for women. Or is it 4, no more than 2 drinks per day with 10 drinks weekly maximum for men, and no more than 1 drink per day with 5 drinks weekly maximum for women? Or is it no more than 1 drink per day with a weekly maximum of 5 drinks weekly, regardless of sex? So I hope you all have had a chance to select your answer. And I guess we'll see what the options are. So it looks like 35% of you thought that the low-risk drinking guidelines were no more than 1 drink per day with a weekly maximum of 5 drinks weekly, regardless of sex. And that is actually not true. That is much lower than our low-risk drinking guidelines as defined in Canada. So I will close this, but very interesting to see that. Hold on. Actually, in Canada, the low-risk drinking guidelines suggest no more than 3 standard drinks per day for men and 2 for women, with a weekly maximum of 15 drinks for men and 10 for women. So obviously this is much higher than most of you thought, and this is for the general population. We actually, at this current point, do not have specific guidelines for older adults. But really, these low-risk drinking guidelines that we follow are designed and developed for healthy individuals. So they do not include individuals with serious health problems, such as liver disease or psychiatric illnesses. Those taking certain medications, such as sedatives, sleeping pills, painkillers, antihypertensives, and psychoactive drugs, probably shouldn't be drinking this much. And also those with a personal or family history of alcohol use disorders. There are other caveats that I haven't included here, including obviously pregnancy. That tends not to be an issue with older adults, so I didn't include it. But you can see how seniors with higher, degrees of comorbidities in terms of health conditions, more likely to be taking medications. they could fit in with any of these caveats. So generally, we do suggest that older adults should be drinking less than the recommended low-risk drinking guidelines. And so, so far in the States, they come up with their suggestion for what moderate consumption levels for a healthy older adult should look like. And they've capped it at 1 drink per day. So you guys were all on the ball with the American guidelines, which are actually better guidelines specifically geared at older adults. And so that's 1 drink per day and not a drink every single day. So, and as well for special occasions, there's a maximum of 2 drinks per day. I am part of a working group right now through the Canadian Coalition of Seniors Mental Health, and we are actually in the process of developing new low-risk drinking guidelines for older adults specific to Canada, and they will be coming out in the winter. We also have a few other working groups, one looking at cannabis use, one looking at benzodiazepine use, and the other one looking at opiate use. So that's some wonderful work that's being worked on right now, and hopefully we'll be able to share with you by the winter of, hopefully by the end of the year, early next year. So when we look at the prevalence of past year drinkers, so this is a person who's had at least 1 drink in the past year, you can see generally across the lifespan, you see a decrease in drinking. You see that for the total group, which is the yellow line, there's a nice decrease in drinking across the lifespan. What's interesting is there's actually a little blip for men, specifically just for men, where there's an increase in the number of drinkers from 65 to 75 to 75 and older. So that's an interesting new change that wasn't in the data before. What we've also seen, what age is considered an older adult? That's a wonderful question. Generally, when we talk about older adults, we're talking about 65 and older. Some of the literature suggests, especially the American literature, because in the States, an older adult is 55 and up. And so we generally say 65 unless there's some age-related things going on that might make you think that someone between 55 and 65 might also sort of fall into that category. It really depends on the health of the individual, I would say. So going back to the prevalence, what you'll notice over time is that in the 90s, the prevalence of drinking in the past year was somewhere between 50 and 60%. Go forward about 8 years, and that's jumped quite a bit, about up to 10% if you look at the oldest group over here on the right-hand side. And just from 2003 to 2004, there's even a steeper increase in the prevalence of past year drinkers. So although with the previous diagram, you could see there was generally a decrease in the prevalence of past year drinkings, what we've seen is with time and with changing cohorts, we're seeing more and more older adults drinking a little more regularly. And this one is pretty eye-opening as well. So the data seem to suggest that it seems to be more of a problem with older men than older women. But if you look at respondents who state that they almost always drink with meals, you can see that across the lifespan, women are the one who are changing their habits. Men are doing it as well, but not as much as women. So we can't just say that it's an issue to be looked at for older men. This is actually something to look at for men and women. When we talk about alcohol-related behavior, obviously there's a spectrum. So on the one hand, we have clinical psychiatric criteria for something like an alcohol use disorder. So previous definitions in DSM-4 looked at abuse and dependence. The DSM-5 looks at severity level. But generally still map on to the similar definitions. ICD-10 and the World Health Organization have acknowledged that, you know what, there's something in between where individuals are drinking and they may not meet criteria for an alcohol use disorder, but they're still experiencing negative consequences. So they coined the terms hazardous and harmful drinking. So harmful drinking, closer to what an alcohol use disorder looks like, sometimes also called problem drinking. But the hazardous group are those individuals that are probably drinking at levels that are placing themselves at risk for alcohol-related consequences. And Oslin also came out with different definitions where we looked at heavy drinking at one end, at risk and problem drinking sort of in the middle, and then there's that low risk drinking as well as abstinence on the other side. So we're looking at a spectrum of behavior. Most of the screening tools that have been developed to look at alcohol-related problems have really been focused on alcohol use disorders. So they really map onto the clinical psychiatric criteria. But unfortunately, we know that lots of older adults still experience problems without meeting that criteria. And so more screening tools nowadays are looking in that gray area. So we're looking at more at-risk or problem drinking or hazardous drinking. When we look at the prevalence of alcohol-related problems, it varies depending on what definition you use for an alcohol-related problems. If you use strict psychiatric criteria, such as for an alcohol use disorder, we're looking at 6 to 14% of older adults 50 years of age or older. If we look at a more inclusive definition, such as problem or heavy drinking, so that those include individuals with alcohol use disorders, but also some that don't meet criteria, we're looking at upwards of 25% of older adults 50 and older living in the community. When we look at more medically compromised individuals, such as medical inpatients or institutionalized seniors, we're looking between 50 and 60%. So you can see how the net we're casting is getting larger and larger depending on the definition you use. So if we use a more inclusive definition, you see more individuals with problems. So the reason why we look at older adults as a specific subgroup and why we need specific criteria or recommendations for older adults is physiologically, older adults are different. We know that with age, the body changes. So we know that smaller amounts of alcohol are actually required for intoxication for an older adult compared to a younger adult. And we know that because there's a decline in lean mass, a reduced water content in the body, and a decrease in gastric alcohol dehydrogenase enzyme, which means that when an older adult drinks the same amount of alcohol as a younger adult, because of the body chemistry and the reduction in water content, there's a higher concentration in that older person's body of alcohol than in the younger body. As well, we also know there are prolonged effects of alcohol because of a decline in kidney and liver functions. Those organs just don't work as well as they did in their 20s. And so what we know is that alcohol, it's more concentrated in the body, but it also stays in the body longer. Oops, sorry about that. There we go. And we also know that there are a number of psychosocial risk factors that can place older adults at risk for alcohol-related problems. So lots of things are changing in an older person's life. Retirement is a huge change for many, many older adults, especially those who have been working all their lives and who define themselves by their occupation. And so changing that can lead to a change in their self-esteem, their level of self-confidence, their personal meaning in life. A lot of people derive pleasure and meaning and feelings of usefulness and worthfulness through their role and occupation. As well, there can be a significant change in standard of living if individuals haven't been saving appropriately for their retirement. And so that can be really challenging for a lot of older adults, and I'm sure that you've seen that in your clients as well, where they go from a great paying job to retiring and just living on the two incomes that are fixed, that are coming to them, and can be really challenging. It often results in a change in their quality of life, their standard of living. They can't do the things that they used to do, and so that becomes a real challenge for a lot of older adults. There's other major losses as well that can occur, like loss of loved ones, divorce or separation, empty nest, decreased social network as their peers are moving away or passing away, change in their physical health and vigor, and also a change in meaning of life. And so with all of these challenging changes that can occur in older age, they have to have some robust coping strategies. And if they don't have those robust coping strategies, alcohol can be something that can be used to meet the need in the short term, but obviously not helpful in the long term. So here is a list of some of the common symptoms of alcohol misuse in seniors. I won't read them out to you, but what you'll notice is that these symptoms are fairly non-specific. They could be related to alcohol problems, it could be related to depression, dementia, or just the normal process of aging. And because these symptoms are so non-specific, that's one of the reasons why alcohol-related problems is really under-detected in this older age group, is that lots of clinicians are just misattributing the symptoms of alcohol misuse to something else that's also prevalent. So when we talk about screening, I want to clarify that screening is really just making a probability estimate that someone has what you're looking for, and it's only obtained through brief questioning. And that can be contrasted with a diagnosis, which requires a full and complete assessment, which is often lengthy to determine if someone's got something that you're looking for. And when we look at screening tools, we're really looking at two things to really gauge how good it is. The first is sensitivity, so the accuracy with which a test can identify a person with a particular problem. That's first and foremost, but specificity is also important. So it refers to a test's accuracy in identifying persons who don't have the problem at hand. So we want to rule out someone with a problem if they don't have that problem there. So that's going to be important as we talk about screening tools. When we look at screening practices, we know we're probably not doing as well as we should be. We know that physicians speak to patients about their alcohol use less frequently than other health-related behaviors, such as smoking, exercise, diet, those types of things. Only about less than half regularly ask about alcohol intake on a single occasion, and very few of those individuals who are regularly asking use a formal screening tool. And that's not to say that a formal screening tool is the be-all and end-all, but it does provide a consistent way of eliciting information about alcohol, and we want to make sure that the way they're asking about it is actually effective in eliciting that information that you want to hear. So we don't want something that's confrontational that gets people's back up and makes them just deny that they have a problem. Generally what we see is that physicians and nurses only ask about alcohol use for people who present with alcohol problems. And the challenge with that is that we're missing a whole spectrum of individuals who may not acknowledge or understand that they might have a problem with their alcohol use. Denial certainly is big in the field of addictions, and definitely, especially with the older adult population. We know that physicians are able to detect 60% of younger patients with alcoholism, but only 30% of older patients with alcoholism. And of those that are identified, very few of those get referred for treatment. So certainly screening needs to be done a little bit more consistently and with a valid approach. And certainly that's where we're going in this presentation. So just a few points about what one's general approach to alcohol screening should be. And this was developed in 1998 by the Substance Abuse and Mental Health Services Administration in the U.S. Department of Health and Human Services. If you Google TIP protocol, I forget what it is, 26, it's a beautiful, extensive document that really talks about screening, assessment, and treatment of substance use disorders. And it's so thorough. And so I've picked a lot of those items from that. And a lot of these will also be in our guidelines that I'm part of developing for the Canadian Coalition for Seniors Mental Health. So generally, the general approach is to be non-judgmental, non-threatening. Be sensitive to the stigma associated with alcohol-related problems in an older cohort. We know that older adults grow up with the mentality that, you don't air your dirty laundry. You don't share personal things about yourself. You don't let other people know when you're struggling because it's a sign of weakness. You deal with it yourself. You suck it up and you just deal with it. And because of that, I mean, it's really difficult to tap into some of those problematic discussions. And this is true for any sort of mental health issue, not just alcohol-related problems, but stigma still is quite prominent in the older cohort. And so what the suggestion is always make the assumption that the person consumes alcohol. I put resident, but I mean the person. We know if we normalize it, they're more likely to not be defensive about their drinking. So, and besides the fact that we know that upwards of 80% of older adults have had at least one drink in the past year, so we know they're drinking. Let's just acknowledge that and move and normalize that experience. And always put the discussion in context of their medical health or nutrition. We know that older adults are more open to discuss their physical health problems, and they just might need to see how alcohol affects their health. Please avoid using stigmatizing terms. Don't say alcoholic. Certainly when you say the word alcoholic to an older cohort, what they imagine is like the Skid Row alcoholic, which is a homeless man living on the streets, drinking bottle to bottle and not able to keep up with self-care or anything like that. And that's what they're avoiding when they hear the conversation about, are you an alcoholic? So we need to use more friendly terms. You'll hear me say alcohol misuse, alcohol-related problems, that type of thing. And that's a much more approachable way to discuss alcohol use with an older adult. And you may need to speak with family friends for collateral information with the older adult's consent, of course, especially if you see that the senior displays any denial, defensiveness, or if there's even any cognitive impairment involved. Certainly we know, especially with dementia, there's a lot of anosognosia. So there's a lack of insight of what they know, of what's going on. And so that can be prevalent as well with their alcohol use. And always ask about a family history of drinking problems. We certainly know there's a lot of evidence that supports that drinking problems, there's a genetic component to alcohol use disorders, but there's also a learned history as well. So if you have parents who were drinking to cope, that becomes something that becomes part of your toolbox potentially, right? And so we want to know about those things. So here's the second real-time poll. I know you're all excited. Which screening tools have you heard of? Caitlin's going to put up some options for you, and you can select multiple responses. So have you heard of the CAGE? Have you heard of the audit? Have you heard of the SMAS-G? And have you heard of the SAMI, or have you heard of none of these? So I'll just give you a few minutes to, do I need to do anything to see the polls? The polls just come up on the screen, and I think you just take your mouse and you click the answer that pertains to you, or answers, depending on the situation. All right. We're just checking to see if someone else. Okay, so some of you may not be able to see the poll. I'm sorry about that. I don't think there's anything I can do on my part, but I do want to move along in the presentation. And the answers, lots of people have heard the CAGE, and that is very true in practice. A lot of people like to use the CAGE because it's 4 questions, it's quick and dirty, but unfortunately it's not super great with older adults. The audit is good, thorough. We've got 21% seeing the audit. And I'm wonderfully happy to see that 31% have heard of the SAMI. Thank you very much. Not that I get any money from the SAMI. It is completely free and downloadable, but I'm just excited that it's spreading out there. So let's move on from the poll. I think we can close it. And then we're going to go into the discussion about the Senior Alcohol Misuse Indicator and the SAMI tool. So this was something that was something that I did for my master's project at the University of Toronto in conjunction with the Center for Addiction and Mental Health. And really the goal of my project was to develop and validate a senior-specific screening tool to identify alcohol-related problems. Previous to the SAMI, there had been 2 other screening tools that were developed for seniors. One was the SMAS-G, which is the short version of the Michigan Alcoholism Screening Test, geriatric version, but it was validated and really used to see and identify people who met criteria for alcohol use and dependence. And the other one that was developed is sort of an offshoot of the audit called the ARPS, and it's sort of morphed into something different. It's out of, I think it's UCLA, but it's really not accessible for clinical use. It's only for research use, and it's fairly long. So I wanted to develop something that was very quick and dirty. This is only 5 questions. And really what was unique to the SAMI is that it was aimed at providing healthcare practitioners who did outreach care with a tool that could be helpful for them in talking to their clients about alcohol use. Because when you're going into someone's home, you have to be fairly non-confrontational because you want to be welcome back. You want to maintain that therapeutic relationship. So that's going to necessitate you to avoid confrontational language, such as in the cage, as well as the audit can also be a little bit confrontational. So it's really, the goal was a softer approach to screening alcohol misuse. And so what we did is we brought together a focus group to develop items for the SAMI tool. We whittled it down in the focus group to 5 questions, and then we fine-tuned those questions with field testing. So we asked outreach healthcare providers to use the tool in their practice, and we got feedback from them about how it was to use the tools and what changes in language or topics that they felt would be more helpful for them. And so that was my master's, and for my my PhD dissertation at Queen's University, I cross-validated the SAMI tool. So I compared it with other tools that are available. So I did compare it to the CAGE and the SMAS-G, and the SAMI came out on top for both of those. So here is what the SAMI looks like. I hope you're able to see it. It's a little small text, but the first portion are the questions, and the bottom portion is the scoring key. And I'm just going to move to the next slide because I've zoomed in so you can see the questions a little bit better here. So the first question is 2 parts. So it's basically a checklist for physical or emotional symptoms that may be caused or exacerbated by alcohol use. And I have a question: is the tool appropriate for an acute care environment? I would think it is. It's not been validated in an acute care setting, only just community. But that could certainly be somewhere we could be going next. So again, it's just the checklist. So it's an easy, soft approach. Older adults don't mind talking about their health. So that's where we started, is let's put this in context of their health. The second question is the consumption question. So we asked, do you enjoy wine, beer, spirits? We use the word enjoy because it has a positive connotation. And we explicitly say wine, beer, spirits rather than alcohol, because some people have differing definitions of what alcohol means. Some people don't consider beer to be alcohol, for instance. And then after they say that, we say, which do you prefer? And so they list what they prefer. The third question looks at how their consumption of alcohol has changed across their lifespan. So as your life has changed, how has your use of wine, beer, spirits changed? The fourth question is not scored, but it's actually clinically interesting. So you ask, do you find you enjoy wine, beer, spirits as much as you used to? And so for some individuals, they'll say, yeah, I still like it and enjoy it. But if people aren't experiencing the hedonic effects of alcohol, that's kind of clinically interesting. So you're not enjoying it. So why are you still drinking? Because that could lead to a discussion about if you're drinking because you're avoiding withdrawal symptoms or you're using it as a coping strategy. That might be sort of clinically interesting for you to know. The last question, and the fifth question, asks the respondent to consider, of all those things that you mentioned in the first question that you're having trouble with, do you think that your use of wine, beer, spirits might be connected? So in some ways, it's asking them to make the link between their alcohol use and their physical and emotional health. Some older adults have never even considered that alcohol could be playing a role in what they're experiencing. And for the most part, some older adults say, well, I've been drinking all my life. That hasn't changed. Just these symptoms have changed. And then that could actually lead to a discussion about how, the physiological changes actually do affect the way you process alcohol, and actually could have a more effect on these symptoms. And so really what the last question is sort of like almost like a brief intervention. It's asking them to consider and looking at the connections between their health and their use of alcohol. So because the SAMI is a fairly friendly, soft approach, open-ended questions for the most part, it's not easy to score, because it's not tick yes or no, and then you just count all the yeses and that's your score. Because it's a softer approach, I have to argue that the scoring is going to be a little bit more challenging. So there are some single responses that lead to a score of 1 and some multiple responses. So if the person responds to question 2 by saying, I enjoy all of those types of alcohol, or if they say, I enjoy a combination of 2, for instance, I like wine and beer, that gives that person a score of 1. If they say in question 3 that they've increased their alcohol consumption from when they were younger, that's a score of 1. So you just check that box. If they say in the last question, yes, there actually might be a connection between my alcohol use and health, then that's also a check of 1. So you add those checks for a score out of 3 for the single responses. Looking at the multiple responses, there's only 2 here, but if they say that to question 2 that, yes, I do enjoy alcohol, and in question 3 they say, I haven't really changed my my alcohol consumption, it's the same as it was when I was younger, then you check for a score of 1 to that part. If they say, yes, I've experienced 5 or more of the symptoms in question 1A and 1B, yes, I do enjoy alcohol from question 2, and if they indicate any current alcohol consumption, then you're going to want to check that box on the bottom right. And you count the number of boxes on the right-hand side for a subtotal of 2. You calculate subtotal 1 plus 2 for your total score, and that's out of 5. And really, you just need a score of 1 or more to flag as a potential at-risk or problem drinker with the SAMI. At this point, I usually have a number of people listening who say, well, if I completed the SAMI, I would score positive. So what does that mean about the SAMI? So for one, you're probably not in the age group that the SAMI is really aimed at, first and foremost, because you're all young and young chickens here. And the next part is really, this is a soft approach. And so we need to find subtle ways to identify individuals who might be drinking at a level that might be placing their health at risk. So if you know someone who has increased their alcohol consumption from when they were younger, generally that does mean, generally as we get older, we drink less as we get older. So when there's an increase, that's going to be something that you should be watching for, right? If someone acknowledges that they haven't changed their alcohol consumption, well, you have to follow up with that too, because if they were binge drinking in their young adulthood, could they still be binge drinking now? So that's why we need to ask those additional questions about some things like that. So that's the way it is scored. I apologize, it's so challenging, but I think that with practice it gets a lot easier. And I did briefly mention that the SAMI is available, free, downloadable, PDF fillable form, available through the Portico at CAMH. And so all you have to do, you can write down the web link at the bottom, which is very long, or you could just Google SAMI, Portico, CAMH, first hit on the top. That's how you find it. And then once you download it, you can just save it to your computer, and then it's with you and it's good to go. So that's how easy it is to grab the SAMI. And it is, again, it's free for anyone to use. So what I'm going to do with the rest of the time is I'm going to go through some of the case examples, 2 case examples, and the use of SAMI. And then I'm going to end the talk briefly. I guess I didn't mention that in the outline. I'm very sorry. I'm springing this on you. I hope you won't get too upset. I'm going to be talking a little bit about harm reduction approaches. So what can we as clinicians do, even when we don't have addictions training? How can we help the older adult? Yes, it would be great to have SAMI as an app, and we are certainly having or trying to have discussions with CAMH to make that into use. So our first case example is Ms. L, and she is a 66-year-old woman living with her husband at home. She has an 8-year history of excessive drinking where she consumes. So someone asked if the tool has been validated in acute care, and the answer is no. It's only been validated for outreach and community settings and clinics. So Ms. L has an 8-year history of excessive drinking. She readily admits to consuming 1 bottle of red wine per day, which is about 5 or 6 glasses per day, and that she began this this level of drinking as a reaction to increased stress at work. She was a consultant and she worked from home, so she took on projects as she needed, and then there was often deadlines that added to her stress. She was referred to me because she was expressing suicide ideation. She was diagnosed with depression, and there was also this background of alcohol use. And so some context for this individual is there was a stressful situation with her daughter, who was also a significant drinker, and who was fairly dependent on her mother to help her out. So if her car broke down, she was calling her mother in the middle of the night to come pick her up, and she had to do it right away. And so that stressful situation led to my client's increased drinking, low mood, some fairly passive suicide ideation. I mean, I think she had a plan, but she had virtually no intent on following through with it. But I think the thought of developing plans was fairly scary for her. She also noted some extreme agitation with physical and verbal aggression, often lashing out at her husband who was at home with her. And she called the crisis line. She was sent to the hospital ED, but sent home after sobering up, and the referral came to me. And so just a little bit more context with her challenging daughter with addiction. So she really felt that she was being manipulated from her daughter because her daughter was constantly in need of financial and instrumental assistance for anything. And then certainly Ms. L was not able to say no to her daughter, which we tend to call in the addiction field enabling behavior. But really what Ms. L was trying to do was to keep her daughter alive. But it was costing her. It was really affecting her mental health to continue to do this. What added to this was that her husband was not on the same page as her. So her husband really disapproved that Ms. L would drop everything to save her daughter or help her daughter in those situations. And she really felt like everyone she talked to about the situation, she felt a lot of judgment from others. And she really felt that this particular situation with her daughter was just hopeless, that there was nothing she could do to fix it. And so she did voice the plan of ending her life by walking into a river, but she also said that she would never do this because she was afraid of water and she just wouldn't put herself in that position. When we talked about her family history, she did talk about a strong family history of alcoholism. So both parents were heavy drinkers. Her brother was a heavy drinker, especially in response to stress. So it certainly was shown to her in her upbringing that alcohol is a great way to relieve stress. And so there was some verbal abuse in her childhood, as well as one incident of witnessed physical abuse between her parents that she found quite upsetting. So she did have a fairly tumultuous childhood. Didn't learn a lot of good coping strategies at that time because she was watching her parents having challenges with coping. Her medical history was positive for sciatica and some undiagnosed abdominal pain. So there were some medical issues going on. Pain was certainly an issue. And she had a fairly interesting psychiatric history. She had 5 previous overdoses and subsequent hospital visits, often triggered by relationship difficulties. So I think she was on her 3rd or 4th marriage at the time that I saw her, and the breakdown of each marriage or relationship often led to one of these overdoses. The most recent was 15 years ago, which was what prompted her 3rd divorce. She had been previously treated with Campril or a Camprosate to no effect. I don't know how long she was actually on it. And there was some question about her level of cognitive status. She had a thorough neuropsychological testing done, which is unusual for some of our clients. And it was queried. She certainly met criteria for mild cognitive impairment, but with the overplay of the alcohol use and the depression, it was unclear how much of a role that was playing. Certainly when we did the geriatric depression scale, she scored 10 out of 15, which certainly would suggest depression was present. And on the Montreal Cognitive Assessment, she scored 21 out of 30. So here's her completed SAMI. So I asked her about those symptoms, and she endorsed changes in appetite and weight, difficulty remembering things, which actually makes sense because of the MCI, feelings of sadness, feelings of loneliness, lack of interest in daily activities, feelings of anxiety, and feelings of worthlessness. And when I asked about wine, beer, spirits, she said red wine all the way. When I asked as her life has changed, how had her use of red wine changed, and she said she had increased her drinking from when she was younger. When asked if she enjoyed red wine as much as she used to, she says yes. And then when I asked her to consider the challenges she noted in the first question, wondering whether red wine might be connected to that, and she endorsed that as yes as well. So you can already see that she's already scoring positive on the SAMI. So in the single responses, question 3 and question 5 were endorsed in that she increased her drinking, and she noted that there may be a connection between her alcohol use and her symptoms. So already she's got 2 from subtotal 1. And when looking at the multiple responses, the second one she endorsed. So she experienced 5 or more symptoms. She said, yes, I do enjoy alcohol. And she was currently consuming alcohol. So that was a score of 1 as well. So put together, she scored 3 out of 5. But again, you only need 1 out of 5 to score positive. So this is not actually a true test of what the SAMI was designed for, because this is a woman who came in with an alcohol-related problem, knew she had an alcohol-related problem, and was very willing to talk about it. So the fact that she scored positive is great, but she should, because she knew she had a problem. So in terms of sharing positive screening results, which is what is the next step after someone screens positive, is really talking to them about how alcohol might be affecting their health or their functional status. So you might say, these screening results indicate that alcohol might be having a negative effect on your blood pressure, your falls, your mood, whatever the case might be. And then really telling them how a reduction or cessation of their use of alcohol might improve their life. So think about their goals. For lots of older adults, we see independence. Maintaining their independence is so important to them. So if they're falling at home, or if they're increasingly confused and not able and putting themselves at risk because they're not being at home safely, cooking safely, whatever the case might be, that's the way to speak to them about their alcohol use. You know what? Alcohol is actually making you more confused. If you really want to, I understand that you want to stay in your home as long as possible. You don't want to move to long-term care, but it's really difficult to do that because alcohol is really affecting your falls. So can we talk about how we can change your use of alcohol to make sure that you stay in your home for as long as possible? So something really patient-focused and really focused on what their goals are, because they all have goals. So other examples are improving sleep, improving their cognition, decreasing falls, or reducing their confusion. So, and always be prepared for options for addressing the problem. Then we're going to move to our next case example, which is based in long-term care. And that's a Mr. C. And you'll notice from the picture why he has named Mr. C. This is my joke for the presentation. So Mr. C is a 72-year-old widower living in long-term care for the past year, with a long-standing history of alcohol dependence, but had been sober for 4 weeks prior to moving long-term care because he was in the hospital. So he was cut off cold turkey and abstinent, and then moved straight to long-term care. When he moved to long-term care, he has doctor's orders for 1 to 2 beers per day, but he has his daughter sneak in extra cans when she's visiting. And the challenge is Mr. C hides these cans throughout his room. And unfortunately, what ended up happening with the home is nursing staff went through his belongings while he was out to sort of take his contraband beer out of his room. And he was also consuming 1 to 2 beers when he was out with his daughter approximately 3 times a week. And the reason I got the referral was because when Mr. C got intoxicated, which was fairly often because he always had a supply of beer, he became very agitated, verbally aggressive, and refused personal care. Also to note, he was also sharing some of his contraband beer with his co-residents, and so they were becoming intoxicated and agitated. So that was the challenge with this particular case. The daughter was the power of attorney who lived just outside the city limits. The challenge with her is that she denied bringing in any alcohol despite being his only regular visitor. And when I talked to her on the phone, I told her, I was referred to see her father. They had some concerns about what was going on. And she was fairly pleasant to me initially until I started to talk about his drinking, and then she hung up the phone on me. So that was a woman who really wasn't interested in changing or acknowledging her role in the situation. So luckily, there was another family member who I could connect with, which was the older son who lived at a distance from Mr. C. And he gave some more context. So we know that Mr. C worked in a high-stress postal career. I put that in quotes because of Mr. C is Santa Claus, until retirement. And I will talk about some follow-up with the cases with interventions in the next few slides. I just want to get through the two cases first. And we know that his wife passed away shortly before he retired. So in response to his wife retiring, his drinking increased, and because you can't sled intoxicated, he lost his job as Santa Claus. Ha ha ha. It's really difficult not having any feedback because it is a funny joke. And he had a very long-standing history of drinking. So we know that he drank up to 20 cans of beer per day and remained upright. So that speaks to the level of tolerance he had developed over time. And he had a significant family history for alcoholism, which he denied. So the question with Mr. C being a poor historian, is this denial? Is this cognitive impairment? What's going on here? And so we're looking at his chart. He has a number of medical issues: depression, diabetes, hypertension, arthritis, peripheral neuropathy, and glaucoma. He did not score depressed on the GDS, and he seemed to be intact with the MMSE 30 out of 30. So certainly looking at this, it suggests, is this person who can consent, and does he want to drink in his own home, which is what long-term care is. So when I went to go see him, he was sitting in his wheelchair in his private room watching TV. I went in there with a very soft approach and told him I was there to make his experience in long-term care better, but that I needed to get to know him and to see how I could help, and would he be willing to chat with me, and he was. And so we spent 30 minutes just talking about psychosocial history, medical history, and then establishing rapport. After 30 minutes, he was in fairly good spirits, and he readily smiled and laughed at all my jokes, which is always a benefit to me. Looking at the SAMI, his completed SAMI tool, he did not endorse any symptoms, and this is a gentleman in a wheelchair, and he has no idea why he's in a wheelchair. So the level of insight is questionable here, right? Especially with his long list of medical issues. When I asked if he enjoyed wine, beer, spirits, he said, "Yep, I love all of them." Asked about the change in his use of wine, beer, spirits, and he said he drank less than he used to. Do you enjoy it as much as you used to? He said, "Yep." And then I asked, well, the last question isn't applicable because he didn't endorse any symptoms, and so that remained blank. So this is a gentleman with very low insight, it seems, poor historian, and he's still able to score positive on the STAMI because he said that he enjoyed all of wine, beer, spirits. So that's this soft, gentle way to identify someone, that individuals who like all of wine, beer, spirits, or combination might be at risk. And that's what the data in our validation study showed. So he did score positive for that. I know in the interest of time, we're running out of time. So what I might do is talk a little bit about harm reduction. So really what we want to do in harm reduction, and any clinician can do this, is we want to improve the older adults' mental and physical health. We want to modify their attitude and behavior, and we want to improve the older adults' living environment. Because really the goal of harm reduction is we're not going to stop them and ask them to completely cut cold turkey their drinking. The drinking is serving a purpose, and it might be social, it might be a coping strategy, it might be something. And so we have to address, why are they drinking? And if we can address why they're drinking and fix that problem, they might be less likely to drink. And so we're looking at the immediate harms in a person's life and helping them work on realistic goals. It helps clinicians start a way of establishing and maintaining a therapeutic relationship without asking them to do something that's totally overwhelming for them, especially in individuals that are too cognitively impaired to participate. And so here are just some basic harm reduction targets. Especially with our latter gentleman, as well as the other woman, depression was a big issue. So we properly treat the depression, will they be less likely to use alcohol as a coping strategy? And I have some other ones listed here. And just some follow-up for Ms. L. She and I began psychotherapy, and we identified a number of triggers for her drinking, communication challenges with her daughter and her husband, her challenges in managing her roles as a mother and a wife, and sort of mitigating that conflict that was inherent in that the relationship between the husband and the daughter. Talked a lot about her stressful job. But the challenge with Ms. L is she was fairly ambivalent about changing her drinking patterns. So we really worked on harm reduction approaches. So we worked on her communication and assertiveness strategies with her daughter and with her husband. They were a common trigger that when they were demanding of her, or they were judging her, or asking or saying negative things to her, she wasn't able to respond in a positive way, and so she coped with drinking. We talked about boundaries. We talked about keeping her distracted and busy when her cravings were at the peak, which often was late afternoon. And so we talked about going out for a walk when you would do that. And when she liked going for a walk, but unfortunately she lived close to the LCBO and she always walked towards the LCBO. So we talked about walking in the other direction so she wasn't tempted by the LCBO. We talked about buying white wine instead of red wine so she wouldn't drink as much because she doesn't enjoy white wine as much. She was really quite challenging to engage. She really didn't take on any of my suggestions. Eventually, what helped for her was she quit her job and she moved to Arizona, so she was far away from her daughter. With Mr. C, I did the MOCA with him, and he scored 17 out of 30. So there was some significant cognitive impairment. So this was a gentleman who did not have the insight to really understand how his drinking might be affecting his health, let alone he didn't appreciate how his health was declining. And so there was a contract was drawn up between the home and the client before I was involved, and I didn't really endorse that. What the contract says was that if he was caught with contraband beer, that he would have his doctor's orders removed. That happened. He was good for 2 days. He was found with contraband beer. His doctor's orders weren't removed. So that's not super great. If you're going to have a contract, follow through with it. But I wanted to focus on the positive. So I wanted him to have some positive reinforcement when he does comply with the contract. So on those 2 days that he complied, could he get a bonus beer that he could drink at his leisure? With him, he talked a lot about moving to long-term care and losing a lot of choice and independence. So he wasn't provided a choice in when and what he could drink. He had beer that was in the nursing fridge that was provided to him at meals. And he didn't want to drink it at those times, but that was the only time he was allowed to drink. So he drank it then. He talked a lot about missing the sensation of opening his own cans and the sound of the opening of the can. If you all know what it's like to open a can, it goes, and there's something, I guess, quite satisfying for him to do that. So we talked about providing a tool that actually would allow him to do that with his peripheral neuropathy. We talked about reduced drinking limits with visits with the daughter, and we talked a lot about treating the depression. So obviously, cognitive impairment made him unreliable to report depressive symptoms, and so that's maybe why he's not endorsing depressive symptoms. So what would have happened if we did an informant depressive scale, like the Cornell, to really look at is depression an issue? Certainly the son had suggested he had been actually clean and not drinking for about a 10-year chunk of time and was involved in AA when he was properly treated for depression. So let's do that. Let's invite and engage this fellow in meaningful activity, make him distracted, get him out of his room so he's not left to his devices with the contraband beer. And we also know that cognitive impairment might make him less likely to initiate participating in groups, so not taking no for an answer, for instance. So in conclusions, we know that senior alcohol-related problems is an issue and it's under-detected. There are some available options for standardized screening approaches. I do talk about the SAMI. The SMASG is also good for individuals where you already have a good relationship and they're willing to talk about their alcohol use. And really, harm reduction is the approach that I would endorse for all clinicians. And here are those cute children who love Star Wars. And I'm happy to take a few questions if there are any. I've been trying to answer questions as they pop out in the webinar. And I'll just leave this poster up for a minute. And this is the clinical guidelines for substance use disorders through the Canadian Coalition for Seniors Mental Health, which is coming out in the winter.
Thank you very much, Dr. Purcell, for your insightful and engaging presentation on the SAMI tool. I know I learned a lot, and I'm sure everyone did as well. We're just coming up to the top of the hour, so I would encourage attendees to please type your questions in to Dr. Purcell now, and we'll take a couple of minutes to answer those. And while folks are thinking of questions, I just had a very quick one for you. Do you think this tool would be appropriate to use with older adults who you know are also using marijuana?
Do you mean marijuana and alcohol?
Yes.
Yes.
This tool would be appropriate.
Absolutely.
Great.
Is there work being done about creating a tool for marijuana use similar to the SAMI?
Not at this juncture. That might be discussed in the guidelines for cannabis use disorders when they come out through the Canadian Coalition for Seniors Mental Health. I'm not at the table for that working group, but I do know that Jonathan Bertram, who's an addictions physician at CAMH, is heading that group. So I'm hopeful that they'll have suggestions on how to screen and assess for cannabis-related issues.
I'm wondering if you have any thoughts on long-term care, in this long-term care setting and harm reduction in the long-term care setting. It's sometimes challenging for the staff there to be in agreement and support a harm reduction strategy when they already see the morbidity that is associated with the alcohol that the person is already manifesting.
Well, every long-term care home is different. I should say that first and foremost. And so some I think are right off the bat refusing individuals who have any sort of drinking problem history. So they don't even get through the door. And the ones who do get through the door, they have the challenge. And really, it's going to be a medical issue. If they want the person to be abstinent, it's difficult, especially if you don't have buy-in from the client, if they're cognitively intact to go along with that approach, and family support as well. And it's often hard because when you see a senior who's been drinking for a long time, there's been a purpose. There's been a use. It's social. It's a learned response. It's a habit. It's a hobby. And so, especially when cognitive impairment hits, the drink is what they go to. And so, I don't love that. I would much prefer a harm reduction approach. And I do find that some homes are more willing to do that. So that's often what ends up happening is prescribing an antidepressant if depression is the issue. But I really think engagement is important. So in long-term care home, getting therapeutic recreation specialists involved, getting them to pull that person out of their room so they are engaging with other people, bringing positive social supports for the individual. So people who don't drink. So lots of individuals, if they've been drinking for a long time, surround themselves with people who also drink a lot. And so they need individuals that would support, a change in their drinking habits. So it is challenging, but for me, it's always going to be about engagement.
Great, thank you for that. There was one final question that came in privately to panelists, and that was how people would refer to the CAMH program.
That I don't know. I work at London Health Sciences Centre in London, Ontario. The work that I did on the SAMI was done at the CAMH, but they do have a geriatric psychiatry program, and I think they have a number that you can call, but I don't have the information offhand. I'm sorry.
Okay, no problem. So we'd like to thank you again, Dr. Purcell, for this great presentation, and thank you too to our audience for your attendance. We'll be emailing out a survey so that we can get your feedback, and we'd also like to invite you to attend our upcoming webinar on October 26th on home and community care experience surveys. We'll send a registration link to that by email soon. Thanks again, and we'll see everyone next time. We're signing off now.